Good morning. We thank you all for being here. I am Eric Peters from the GMSH. I'll be the moderator for this session, and accompanying me is my colleague and co-moderator, Devon Nambia. Today, I'm happy to have the opportunity for us to hear the points of view from three well-respected scholars who will be speaking in the context of Black same-gender loving men. They will tell you a little bit more about same-gender loving, with one presentation providing info on culturally safe and responsive methods that allow for effective PrEP implementation and engagement. The other two will unpack the complexities of this brilliant, often challenging existence of Blackness and queerness, one through the broad lens of theorizing Black sexuality research and addressing HIV inequities, such as structural racism and homophobia, and fill in the blanks. And the final presentation peels back the layers to expose the impact of violence, anti-Black racism, and the intersections of sex, sexuality, homophobia, transphobia, sexism, with a village concept response for healing. We hope that the messages in this session provoke provoking questions to the speakers for an interactive, rich dialogue that can affect change in best practices in service delivery, enhance engagement for and with Black same-gender loving men that may result in uptake with PrEP and drastically reduce the incidence of new HIV infection. Just before opening the space for the speakers, I ask that we get comfortable. This session will run for 90 minutes. At the end of the individual 20 minutes, presentations, the remaining time will be allocated to questions and answers. That'll be facilitated by Devon, who will be monitoring the chat during the presentations and the chat feature at the Q&A time. So kindly place your questions in the chat and they'll be addressed in the order in which they've come. So over to our first speaker, Dr. LaRon Nelson.
Hi, thank you, Eric, and good morning. Good morning to everybody out there in the GMSH audience. Today, I'm going to talk a little bit about, share some thoughts on PrEP use among Black gay men or same-gender loving men in Ontario, and what I think are some of the drivers, what that might look like, and some of the drivers that we should be thinking about in some sort of goal of preventing HIV infections through increasing PrEP use. And I guess I'll say, just to start, a lot of what has been done or what we've sort of thought about with regard to PrEP use has really been focused on behavior, right? Like, in order for PrEP to work from an efficacy standpoint, people have to take it. In the current formulations, oral PrEP, which is Truvada or Descovy or the generic versions of it, they really depend on people taking it daily, ideally daily, but as much as possible in order for it to have the protective effect that it should have. And but that's it, right? Like, we need Black queer men who are engaged in any behavior for which PrEP is clinically indicated to just use it. And so that logic ignores a lot. That this is as simple as using it. It ignores these other drivers that we are finding in Canada, but even elsewhere around the world with Black queer men, are these other forces that are at play that really come together to impede the ability for Black men to access PrEP, or to use it, or to even prioritize it. Maybe prioritize is the word I want to use, that to suggest that PrEP use, daily PrEP use, is a thing folks should do, ignores these other systems that are in place that can sometimes impede PrEP use. So let me give an example. In the Lancet, which is this medical journal, I think it's out of the UK, there was a figure published. I think it was earlier last year. Anyway, it was a figure that was showing rates of HIV incidents, rates of new infections. And it was looking at it among men who have sex with other men, and it was biracial group. And I think it started from like 2010 or 2000 through 2019. And you could see at points along that graph where the line between the Black men and the white men were diverging. So the HIV incidence proportionally was always higher in Black men compared to white men. So they were always high on that graph. But as time went on, you saw that line begin to split, because not because the HIV incidence went up necessarily, but because the incidence among white men was decreasing over time, and the incidence among Black men was not changing. And so a group of us looked at that and were trying to understand what was happening there. And so we looked at different points on that timeline and said, what was happening here when the incidence among white men started to go down? And I think that was like when the rapid point of care testing had started, right? And what happened here? Maybe that was when treatment as prevention was starting. We knew about the benefits of viral load suppression, and what happened here, and this was PrEP. And so we could see that at these different points where these innovative public health clinical strategies were introduced, you could see the impact. But the impact was a racialized impact. The benefit of those innovations were almost exclusively among white people. That Black line did not change, right? And the white line went down dramatically so. And so it made me think about, so what does that mean? Because you would expect that these new innovations would have an impact. And what we concluded that it meant is that even though these innovations are new, the structures are the same. The same structure that disadvantaged Black men did not change. So when these new innovations come to play, it benefits who the structure will dictate it will benefit. And when I say structure, I mean healthcare systems, principally, one of them, but social systems and social processes that organize power relations between Black people and white people in these diaspora contexts. I'm talking about Ontario in some sense, but you see the same thing in the United States and in the United Kingdom. And so we thought about what then, if we know this, if we can look at this map and see that, you can introduce as much as you want to, but introducing a new innovation is not going to be enough to address the epidemic sufficiently in Black communities or in Black queer communities. And even though there's sort of talk about these new potential PrEP formulations, right? So right now, there's a lot of excitement around long-acting injectable cabotegravir that does not have to be taken daily. There's even sort of long-term thinking. There's some trials happening now with a monthly oral drug, islatravir, which is currently in trials. But like that sounds promising. Like, yeah, you could take a pill. So that's the difference between 365 pills a year and 12 pills a year. That sounds like something that might be feasible. But if we have not changed these systems and structures, I think we might see the line continue to go down for white people and not change for Black folks. And so some of that is, how do systems engage with Black people, Black queer men in particular, that undermine PrEP use? Some of the work that my team has been doing has been looking at what happens specifically within healthcare systems. I'm a nurse practitioner, and much of my work, I guess, how I think about this in a lot of ways comes from the lens of being a nurse, is my clinical background. But actually what happens in that healthcare setting can actually frame the degree to which Black men decide to use PrEP, whether we can support their decision-making on whether PrEP is right for them, or whether we create situations where they are turned off from it, right? I think partly the ways in which healthcare systems, nurses, physicians, receptionists, security personnel, whoever's working in these systems, understand Black queer men particularly, right? So you can go to a place that maybe they're Black centered, maybe that's their specialty, maybe it's Black led, And so maybe there is some part of it that feels affirming as a Black person in those spaces. But the ability to bring up this topic of PrEP to the provider, if you're a Black queer man, meaning you need to introduce the topic of your sexuality or your sexual behavior in order for the clinician to even know that this is a relevant conversation to have with you. And that can be, if the environment is not one where you feel safe to say those things, to talk about the anal sex you enjoy or that you want to have, if it doesn't feel safe, then it doesn't come up, even though the door is open, even though you booked the appointment, even though you went to the clinic. If the environment is not affirming, right? If there can be signals, sometimes often signals that you get that suggests it might not be safe to say it, right? So when the physician or nurse doesn't ask about the range of your sexual behavior, they ask, there's a heterosexual assumption in that I think providers put on Black men. There's actually literature that talks about questions that white men get asked that Black men don't get asked, that Black men are less likely to be asked about anything other than penile vaginal sex, maybe oral sex, but very rarely do providers ask about anal sex, unless the Black person has particular presentation, maybe that might suggest they could ask it. If they're more feminine in some ways, that might lead the provider to ask those types of questions. But otherwise, it doesn't get asked because the assumption may be of heterosexuality. Or in some instances, there is this I want to say fear. I think it is fear. I don't know whether it's homophobia that's sort of reflected onto the patient or that the providers have, but there's been some documentation about fear of asking Black men about the range of their sexual interests or desires or practices. So that might be the case. Maybe that the providers feel that way. But what it means is that the right questions in those clinical encounters don't get asked, right? So you have PrEP that's available. It's a prescription on the desk on the side. There's a pharmacy filled with medication. But then these systems that interact with Black queer men in particular ways still create situations that impede access to PrEP. I think the other challenge is that there are other material priorities that Black same-gender-loving men have. And the challenge with PrEP uptake in this group is it's not a whole conversation about the person's life experience that might include PrEP. And what then we ask people to do is not think about these other things that might have more immediate relevance or salience for them. So it could be housing, right? Could be challenges with immigration or citizenship, could be violence and sort of trauma exposure, could be employment, could be a lot of things, could be in the family context that they're living. But the PrEP conversation can be about focusing on, here's a pill that you should take, without taking into context or consideration these other things that people have to figure out, how am I going to prioritize? And so there has been some work, and even some that we've done in Ontario. Some of this thing we've actually been doing with GMSH is about how do we work with providers to better understand how to provide PrEP services that are more responsive to Black same-gender loving men, to their intersectional identities, but also to the sort of potential realities that could be complicated, that can make it difficult for them to decide that PrEP is the thing I want to focus on if there are other pressing issues that should or may require focus. So it's important to say that because what the implication is that the intervention or the work that needs to be done at this point is not really on Black men, it's on these systems that the target of the intervention what needs to change essentially is the systems that create that disparate, that line that I told you about, that diverging graph line. And so what I'm sort of proposing is that the work now in Ontario to sort of improve PrEP coverage or increase PrEP coverage among Black women should focus on structural issues or changing healthcare system environments such that they can be more responsive to the wider range of needs that Black queer men have. And not just healthcare systems, but social systems. I think the way government systems work, those things need to change. How we do it, it'd be interesting to have a discussion about that among my panelists here today. But how we do it is another question. I think it's possible. I think the real issue is the will, because some of what needs to change are not changes that are just specifically to how Black queer men are marginalized. It's about how Black communities are marginalized. And I think that the implication of that elicits this sort of defensive responses from leaders, policymakers, stakeholders, even leaders in organizations who have an interest in making sure that that system stays in place the way it is. So I think what we see in the inequities in PrEP are about our manifestation or reflection of these larger inequities that we see among Black communities and the ways that Black communities are marginalized. And I think maybe the last thing that I'll mention is, I think there's also ways, I didn't talk about stigma, but stigma is this sort of very complex phenomenon that is, the more we sort of understand it, the more complex it becomes. But I think there's these different ways that the stigma around HIV, even for people who are not living with HIV, but the stigma around HIV, around their same gender sexuality, even around medication taking, also converges in a way that can become internalized, that I think we have to figure out, maybe there's some work in helping to figure out how we undo that stigmatizing work that essentially allows for individuals to sort of adopt these codes, right? These thoughts about whether or not Black gay men can do it, or whether they will do it, or what that means if you have to be a person, or if you are a person who's choosing to take PrEP. What does that mean about your sort of moral sexual behavior? What does that mean about how risky you might be such that you use medication to protect your health? So that is more, I think we talked about it initially, at least in the scientific world, about what we thought what impact that might have. But the more we look into it, it seems to be a very pressing issue around the complexity of the ways in which people internalize these stigmas around these particular topics that are not separate, but they are sort of interlocking topics that I think impede, at least on the individual level, Black men's interest or engagement in PrEP. But some of the ways in which these messages are conveyed to Black MSM still happen through systems, family systems, religious, and I think in some ways principally healthcare systems. So I think I'll stop there with my comments and be prepared to talk more about it when we get to the Q&A. So thank you.
Okay, thank you, LaRon. Up next, we'll have Dr. Leo. And Dr. Leo, this is the first time you're meeting this. If you could give a brief introduction to as well, appreciate that, thanks.
Sure. Good morning, everyone. It's my pleasure to be here. I very much appreciate the invitation to be in conversation with Dr. Nelson and Dr. Timothy and all of you around these very important and germane issues. I'm a full professor at the State University of New York at Binghamton in the Department of Human Development. And that is in New York, in the US. My research focuses on looking at structural factors and also sociocultural factors that impact Black communities in relation to race, gender, and sexuality. And I'll talk more, you'll see, some of these threads kind of come through, but I really do a lot of field work, in partnership with non-governmental organizations and community-based organizations within the US and beyond, in Africa and also in the Caribbean, and so forth. So, and I look forward to talking with folks here. Could everyone see my slide?
Yes.
Leo,
Okay.
we can see them. You just might want to, yeah, there you go.
Thank you. So today I just have some opening comments, that I wanted to begin to kind of address and invite us to think about, but around theorizing Black sexualities research and addressing HIV-related inequities for Black same-gender practicing men. Essentially, if we're thinking about research, we also have to be thinking about, theory, but what's happening at the ground level. So to really begin to kind of unpack some of the structural inequalities that we're thinking about. And, if we're thinking about some of these things, one key, piece here is in terms of addressing the very pervasive and persistent HIV-related health inequities for Black same-gender practicing men's communities. The theoretical frameworks must be, grounded within culturally relevant conceptualizations. It sounds basic, but it's actually not. And we can begin to kind of get into that some more. And thinking about, the critical analytic frameworks around theory in relation to HIV prevention research that we're thinking about. So what's happening, and so how are theory, methodologies, and praxis in conversation with each other, right? And how is this kind of connected to the intersection of race, gender, sexuality, social class politics, for example? So what I hope that we can do today is just spend some minutes to really, think about, the need for a paradigm shift that links HIV prevention within interdisciplinary and intersectional frameworks that are relevant to the life experiences of our communities at the ground level. And I would like to do that by, inviting the spirit of Mother Audre Lorde into the room. Some of her words here that I really like to work with: unless one lives and loves in the trenches, it is difficult to remember that the war against dehumanization is ceaseless. And I think this is fundamental. What she was talking about, Audre Lorde was talking about, is this paradigm shift, right? And really working to challenge structural inequalities in terms of the state. But it also connects with other people like Ronaldo Walsh, for example, Sylvia Wynter, Jamaican theorist, for example, around dehumanization and anti-Blackness at the center, right? And so part of our panel here today is, inviting us to think about, these larger, frameworks around dehumanization and anti-Blackness from an intersectional lens and that sort of piece. So we have lots of history around this, right? One book is around medical apartheid, the dark history of medical experimentation in Black communities that really looks at, scientific racism, pathology of Black sexualities, medical abuse, experimentation, exploitative research in Black communities, and cultural mistrust, cultural distrust in Black communities about the medical establishment. So we have to really, really integrate, if we're working from a truly interdisciplinary framework, these histories that are very, very important to, these discussions here. And even his recent work, Ronaldo Walsh, on property really begins to help us, think through this within a context of Canada and beyond, right? So where he's really engaging issues around the afterlife of slavery, and how that relates to structural inequalities and anti-Blackness and that sort of piece. And so this work is in conversation with other Black Canadian scholars like Dion Brand, but also most certainly had mentioned Jamaican theorist Sylvia Wynter and some of her work. So again, it's important to think about the theory pieces, right? And so moving beyond these very traditional, and it's much harder than it sounds, right? In terms of moving beyond these very traditional disciplinary boundaries. where we can begin to kind of really integrate multiple bases of knowledge, right? But connected to here, which I think people really miss the piece, is what people like critical race theorists, Kimberly Crenshaw and others are really beginning to, address here for us, have been addressing, for a long time, which some people are just beginning to pick up, but I would say more on a superficial level, right? But it's the relations between dominance and insubordination. So again, the structural piece is often missing here. So the power relationships that are operating in our everyday lives. And connected to that, intersectional theory is very, very important when we're looking at, anti-Black racism and how it's connected to other forms of oppression, vis-a-vis gender, gender identity, gender expression, sexuality, social class, immigration, et cetera, et cetera, et cetera. And how, this is kind of working simultaneously to create and maintain inequality. So again, people like Kimberly Crenshaw would argue that, quote, structural and dynamic consequences of the interaction between two or more axes of domination. So how are these, systems of oppression and domination working, together, and that sort of piece. And then, I would invite us to think about knowledge production and how are we thinking about, the creation of knowledge and the production of knowledge and what constitutes, quote unquote, legitimate knowledge, is an important question that we need to begin to kind of, interrogate. So in the field of public health, for example, the building of knowledge in HIV prevention research is primarily based on, epistemological and theoretical frameworks that are grounded in biomedical and epidemiological research, right? But what about qualitative research? What about cultural studies? What about gender studies? What about sexuality studies? That get put on the periphery, but need to be at the center of the discourse. And, another important first person I would like to invite into the room is Kathy Cohen, Black political scientist, where, even in terms of some of her foundational work, where she's talking about really addressing stigma, marginalization, and structural inequalities, and how this could really help us to provide a conceptual framework for addressing, asymmetrical power relationships or power inequalities in Black communities, including those, that help us to look at this socio-historical context that's very, very important that Ronaldo Walsh and many others are inviting us to think about, but also the political experiences of exclusion and marginalization. And what I really like about her work here is that, so what's happening at the macro level in terms of structural inequalities, but it's also what's happening at the micro level as well. So within communities in terms of disenfranchisement. So it could be based on gender, gender identity, gender expression, issues around, social class, sexuality, for example. So I would invite us to think about broadening, our frameworks and, in terms of looking at cultural studies, African diaspora studies, Caribbean studies, African studies, gender studies, sexuality studies. And these disciplines help us to think through structural inequalities, right? And that sort of piece, which is very, 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 very important. And so helping us to better understand and build knowledge and theory, that provide the basis for helping us think about some of these important histories, political, economic, and cultural contexts that have been integral to Black same-gender practicing men's communities. But again, this provides a nice critical approach to the work on health inequities that help us to engage a critique of macro and micro level, processes that influence structural inequalities, for our communities. And most certainly, I'll be closing in a few minutes, but most certainly, critical race theory has a nice, strong history in helping us to think through this. And critical race theory is a very intersectional theory, right? And that's important to begin to, to acknowledge and to recognize. But critical race theory really did emerge out of scholarly research and activism. So again, the connection to praxis was happening at the ground level. That was embedded in critical legal studies and connected to, civil human rights that really provided a critique of some of the legal theory and discourse that disenfranchised Black communities. But if we're using critical race theory as a theoretical framework, it does provide like a nice basis to help us to theorize, to examine, to challenge the processes in which race and racism implicitly and explicitly impact social structures, practices, and discourses, that manifest within systems of domination. So racial subordination in this case, from an intersectional lens. But the other important piece here, though, is that, critical race theory does hold that the everyday lived realities of communities of color provide, a very, very important context for helping us to think through understanding experiences with racial subordination and systems of domination. So here, the voices of the people are, need to be front and center. So a recent book, again, by Ronaldo and also colleague Ideal on Black life, kind of connects to this discussion on post-Black Lives Matter and the struggle for freedom, where they help us to think through structural violence, and anti-Black racism within Canada and beyond, interrogating and problematizing the Canadian nation state, but even moving beyond that as a framework. They're helping us to think through. So this is an important piece. So strategically, I also was including different references for people, like very, very current references, some classic ones that people can begin to kind of look at, read, and engage. But, you have scholars right here, within Canadian context that are doing this work that's very, 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 very important. And some concluding thoughts is that the importance of the research we need to be looking at to Black same gender practicing men's communities, really being able to think about how to strengthen the capacity, right, for Black same gender practicing men in academic and community context to conduct research, partnerships with community-based organizations. So what's happening at the ground level, and how can we begin to kind of connect with that and, and put that at the center, of the conversation. So with that, I'll stop, and then we could, I would look forward to the next presentation, but also having some other further conversation.
Okay, thanks, Dr. Leo. Up next, we have Dr. Roberta Timothy. And Dr. Roberta, please share a bit about yourself with your introduction and guess.
Thank you. Thank you so much, Eric. And thank you, Dr. Nelson and Dr. Leo, Dr. Wilton, for your introduction. I think it goes well with my conversation today. So I'm going to be talking about Black gay men's mental health. My presentation is called Black gay men's mental health. It takes a village to heal. And in terms of before I locate myself, I want to just do an ancestral acknowledgement. We honor our ancestors who are intrinsically linked to this land and who fought for their survival. Their lessons and sacrifices have led us to gather here today. We actually need to take a second to reflect and honor our ancestors, those who have now journeyed, who provide the footprints in which we stand today. Honoring our ancestors as African folks is really important, particularly based when we're looking at a conversation on healing and empowerment. Our African ancestry and spirituality is critical for this healing. I also want to quickly read an Indigenous solidarity statement as we stand in white settler colony land, Canada, Turtle Island. I stand in solidarity with the Indigenous peoples of these lands and support in their fight for reparations and self-determination, as I know that their struggles are intrinsically related to my own people's fight for justice and reparations, as we are linked through processes of genocide, white supremacy, colonization, and enslavement. I vow that even though we have differences among ourselves, but the divide and conquer supported, sustained, and fueled by the Canadian state through systemic oppressions maintained by colonial powers and white supremacist ideologies will not dictate or reconfigure my connection with Indigenous, African, Black, and colonized peoples locally and globally. In terms of my own location, I'm an African transnational Indigenous woman, Black feminist womanist of West African ancestry. My language, tribe, land, name, and family have been taken away from me through over 400 years of colonization, anti-Black racism, misogynoir, and other forms of intersectional violence. I'm surviving African enslavement through processes of forced migration. My peoples were incarcerated in the Caribbean, Latin America, and North America. And as such, I am intrinsically linked to Indigenous peoples and their struggles for self-determination, reparations, and justice. As a result of this structural violence and what I call health violence, racism, and brutality, I come from a working class background, and I'm always considered a daughter of immigrants. I'm a mother of two living and resisting with a visual disability in Turtle Island. I have been active in the HIV community since I was 15 years old, advocating for safe shelter for women living with HIV in shelters through an anti-oppression framework, critiquing HIV research communities for problematic research on Black women and not including an anti-racist or anti-oppression decolonizing framework in their research and praxis, advocated for research outside of the quote-unquote HIV community to include people living and impacted or affected by HIV. I also was 6 years on the board of Black CAP, conducted postdoc research on criminalization and HIV disclosure from a Black feminist intersectionality lens. I just want to say something about post-trauma. A lot of folks are talking about healing and talking about post-trauma. And post-trauma or post-trauma traumatic disorder does not exist for Black community members, at least that I've worked with. As anti-Black racism and other forms of violence does not give us the luxury of a quote-unquote post. There's daily inflictions and convictions made based on eugenic perceptions of pigment and actions of violence. My work is connected to my lived experiences, and decolonizing, dismantling, and engaging in emancipatory health and wellness through an intersectional, anti-colonial, anti-racist, resistance-centered lens is the work. African Indigenous ways of knowing knowledge is critical to challenging the daily structural violence actualized in Black communities 365 days a year. Just want to give a quick definition of anti-Black racism. It's racism, racist trauma directed specifically towards African Black people based on the promulgation of colonial violence and sanctioned by eugenics-based racial stereotypes that create particular unjust relationships between African Black communities and white supremacist state structures and practices. A quick definition of heterosexism: the violent beliefs and practices sanctioned by state institutions that purport heterosexual identity as quote unquote normal and central to the everyday functioning of society. This is done with the direct exclusion and silencing of diverse sexual identities, such as two-spirited, lesbian, gay, bisexual, transgender, transsexual. Are you okay? Somebody's coughing. Hope you're okay. Transgendered, transsexual, queer, same gender loving, gender non-conforming, and questioning peoples, among others. And I also want to give a quick definition of transgenerational trauma: mental, physical, emotional, spiritual, financial, severe anguish resulting from continuous life-threatening experiences of direct brutality, dehumanization, and extreme violence based on forced African enslavement, colonization, anti-Black racism, and intersectional oppression perpetuated onto generations over an extended period of time. This includes both Africans from the diaspora and Africans who remained on the continent. We're talking about the importance of Black gay men and healing. The importance of healing for Black gay men and our communities there's one main, there's many, it's important for many reasons, but there's one main point that I'd like to share today. Actualizing anti-oppression, decolonizing real social justice. When we talk about social justice and how to practice it. When anti-Black racism, heterosexism, sexism, and phobia, among other forms of intersectional violence, are addressed in the lives of Black men, then we'll actually be doing anti-oppression, anti-queer violence work. Patriarchy and misogyny operate to uphold a white supremacist, misogynist, straight identified world. Black gay men's health and healing through Black feminist, intersectional, African-centered ways challenges colonized notions of masculinity, femininity, gender, sex, and other purposefully marginalized factors relating to Black men and their communities. Black gay men's healing is critical to Black resistance. I just want to quickly talk, and this is, 500 years of history very quickly, the impact of intersectional violence, anti-Black racism, and heterosexism, and give some examples. I first want to say that we, in the Canadian context, we're over 1,190,000 people of African Black ancestry, representing 3.5% of the total population, live in Turtle Island. And 1 in 7 people living with HIV in Canada, 15% are African and Black. The 5 most Black populated provinces are Ontario, Quebec, Alberta, British Columbia, and Nova Scotia. Brazil, United States, Haiti, Dominican Republic, Colombia, and France have the largest Black populations in the diaspora. Over 250 million African people live outside the continent of Africa, most due to the forced migration processes in the past and present. And Africa's population is over 1.3 billion people. This is real critical information about African Black folks that needs to be shared, because when we talk about African Black folks, particularly in the Canadian context, if we don't have a transnational lens, we're talking about 2 million people, and we're usually talking about it as though we are the minority of people. But if we talk about African Black men, gay men particularly, as a part of the world majority, it's a really different conversation. And we know that the reasons why we have an under 2 million population in Canada has to do with anti-Black racist immigration policies. So it's really critical to look at our communities and our collective communities as larger groups of villages. And that's the way I kind of like to look at it in my conversation. And I want to go back to pre-colonization and talk about the importance of our healing. It's also to look at classical and African indigenous civilizations. And this is before Asiatic or European invasion. And the fact that we've had and we have, and we come from many, Kemet, Kush, Twa, Sara, Hausa, Nuk, Yoruba, Akan, Himba, Sen, all of these indigenous populations, Maje, that have really amazing indigenous teaching and healings that we can learn from as African peoples and remember to actually deal with the white supremacy and current anti-Black racism that exists. So we had, many, many thousands of years of African culture, spirituality before colonization, and it's critical to understand those pieces. But it's also important to understand that we are living in a white settler colony. Genocide of indigenous peoples and Black peoples are critical to upholding heterosexism and anti-Black racism. We are still, indigenous populations in Canada are still governed by the Indian Act of 1867. It's really important to understand these pieces. I just want to read a quote from Frantz Fanon. Imperialism leaves behind germs of rot, which we must clinically detect and remove from our land, but more from our minds as well. So again, the impact of colonization, white supremacy, heterosexism, et cetera, impacts our mind as well as our physical health. And we're looking at doing healing for Black queer men. We have to look at how we decolonize our mental health praxis. Also, some impacts of intersectional violence and anti-Black racism. We have to understand and remember the transatlantic slave trade and the earlier East African enslavement are very important to understand. The dungeons are what people call castles, which are definitely not castles, that African people were taken to as a part of the transatlantic slave trade along the west coast of Africa, where Africans were held. It's important to understand what that meant and what that means right now in our current mental health crises. The beginnings of the violent breakup of Black families and the calculating reshaping of notions of heteronormative family life began in those dungeons. That did not include Black folks. It was a white supremacist agenda to not only brutalize Black families, but to also create a system of patriarchy and colonization and heteronormative behaviors and practices that actually continue to harm Black communities today, particularly Black queer communities. It is very significant that the churches that were built on top of these dungeons of enslaved Africans existed. How Christianity was used to support anti-Black racism and heterosexism is critical to understand. It's important also to know about the Middle Passage. Approximately 30 million Black people survived, 15% died. Important to understand the triangular trade between the three ports of region, sugar, tobacco, and cotton to Europe, enslaved Africans to Americas, textiles and rum to Africa. How Christianity was used to colonize Black people is directly related to the current anti-Black racism and homophobia, heterosexism, and transphobia, as well as other forms of intersectional violence. The result was fragmented Black families and ideas of gender, sexuality, and maleness that directly related to Christian beliefs that continued trauma and destruction of Black families. Transgenerational and transnational trauma is the result of these types of violence. Also in the Canadian context, the story of Olivia Lejeune, a young Black child from Madagascar, was said to be the first enslaved African in Canada. The Code Noir is critical to understand an anti-Black racist policy, forcing baptisms and decreed the conversion to Catholicism of enslaved Black people, restricting rights and freedoms, and restricting traditional African spiritualities, and upholding heteronormative practices. The Slavery Abolition Act of 1833, which banned enslavement of African people. However, the ideologies, practices, and actions of intersectional colonial violence and anti-Black racism continue to impact the health of Black communities today. The scramble for Africa is critical to understand 1885 to even now. It can be argued that that still exists. And in 1914, 90% of Africa was owned by European countries. Critical to understand that impact on the lives of Black folks and Black queer folks. The LGBTIQ decriminalization in 1969, 1952, it was a part of the homosexuality was a part of the DSM. It was removed in 1973. It's interesting when we talk about issues of queerness, heteronormativity, the impact of heterosexism, and we have white lens. If we're not talking about Black folks in the queer community and in terms of these types of policies and how they've infect intersectionally anti-Black racism and heterosexism, we're missing the boat in terms of doing healing for Black gay men. Bill C 389 was introduced in the late 2010 to amend the Canadian Human Rights Act to protect the rights of transgender or transsexual citizens. We know that still in terms of Black trans communities, in terms of data, in terms of support in the Canadian context and globally, that anti-Black racism, transphobia are hand in hand, and that the mental health impact is grave. And the fact that we have one of the highest suicidality rates within our communities, and that people keep on saying it, but not much is done to actually make the changes that is needed. In terms of hate crimes, in terms of police reported hate crimes, we know that anti-Black racism and Black communities are one of the biggest hate crimes in the Canadian context. And we know that queer communities are also the biggest hate crimes. Yet there's not an intersectional analysis. There's not hate crimes, hate crimes that happen between Black men, Black gay men, or Black queer women, Black trans communities. We do not have that data. Not having data is also the impact of white supremacy in the system. Like, we not have the data, so we don't have the interventions, right? So we can't prove that these things are happening, even though we know that this is a reality for many Black queer folks in our communities. The impact of intersectional violence also comes in different forms. The notion that Black people are more homophobic than other people, again, is a problematic anti-Black racist perspective that impacts Black folks and Black queer folks. The notion that HIV came from Africa and that Black folks are bringing disease. And we can see that anti-Black racist white supremacist ideology and practice is also, it's very part of our structural system. And our current examples, we can see it in terms of the COVID-19. We've always known that there's multiple pandemics, and that the anti-Black racism, HIV, heterosexism are all different pandemics that are intersectionally happening at the same time. Criminalization of Black men living with HIV are example of impacts. The widespread anti-Black racism in the queer community. A statistical portrait of Canada's diverse queer community was out June 15, and it's still emitting stats on Black queer folks in Canada, still relying on American stats for Black queer communities, which means we're not getting interventions for our communities. We're not having conversations in bigger organizations that actually can support resisting anti-Black racism and heterosexism. Racial profiling, killing of Black men by police and community members, fear of Black men are not addressed. Media portrayals of Black queer men are very limiting, usually related to fashion. Fashion's all good, but it's not the only thing that Black queer men are about. The impact of internalized white supremacy on Black gay men, how Black gay men internalize their oppressions, how they experience internalized anti-Black racism or internalized white supremacy, internalized heterosexism is critical to mental health. Black men's healing is not prioritized within our communities. Everybody knows that, yes, HIV stigma exists. We know that, this is a quote, in Canada, a person living with HIV can be convicted of a crime for not disclosing his or her HIV status to sexual partners. Racism remains one of the most pervasive forms of systemic oppression, impacting on vulnerability to HIV, interpersonal relationships, and how the criminal law is applied. As a result, the criminalization of HIV non-disclosure has been particularly onerous in African, Caribbean, and Black ACB communities in Canada. This is a quote from ACHO 2010. We know that criminalization of HIV non-disclosure in Ontario, the laws have changed slightly compared to 2010, but the impact of criminalization of HIV non-disclosure on Black queer men still exists. And that creates depression, anxiety, isolation, and other impacts still today. In terms of mental health stigma, Black gay men, this is some stigma. Black gay men can't seek mental health services, which is not true, but that's part of the stigma or the thoughts. Depression, anxiety is a white people thing or white queer people thing. It's not ours. The notion of the Superman who can do everything. Crazy and mad people, quote unquote, seek mental health supports. Mental illness means you didn't make it or you failed yourself and family. Black people do not seek mental health services. These are some of the mental health stigmas in the Black queer community, Black gay community. Healing from an African feminist perspective is really critical. For African Black feminists, our feminism includes men, which is very different from white feminism. Our men, children, queer folks, trans folks are always a part of our community. This is a quote from James Baldwin: "Love him and let him love you. Do you think anything else under heaven really matters?" That's from Giovanni's Room for anyone who's read it. It's really critical when we're practicing from a healing perspective that we collectively include elders in our community and elders that are conscious and practicing from a Black-centered, queer-centered perspective. An example of such practice is an approach that I and a colleague have created called anti-oppression psychotherapy. It's a therapeutic approach that therapists and other clinical practitioners can use with clients to support empowerment-centered change process needed to deal with the effects of oppression, trauma, and intersection violence in clients' lives. AOP incorporates both anti-oppression theories and practices in psychotherapy to understand and work with individuals and groups under internal and external distress to the lived experience of oppression, trauma, and intersectional violence. I'm a therapist in the community. I've worked in community health for over 30 years. I worked with many gay Black men and Black queer community in general. And I want to just, before I end with why Black gay men's mental health matters. It's important that we recognizing and speaking up about Black gay men's mental health is resistance, destigmatizing our mental health. Unification of African and African diasporic families and communities depends on Black gay men's mental health. Healing, quote unquote, for Black gay men and Black people and our communities from a critical Pan-African lens that includes heterogeneous notions of wellness is revolutionary. Decolonizing mental health services in psychology and scientific racism in the biomedical model is essential. Training and retaining African Black gay men mental health practitioners is critical. AIDS organizations, queer agencies, and all funded mental health organizations need to allocate and prioritize Black gay men's mental health. We have many organizations who are on this call today. If you want to make a change, if you want to do something different, you have resources, give those resources and set up a program that's specifically for Black gay man's mental health. Resistance is the struggle to survive, exist, persist, and try to eradicate ideologies and practices of colonialism, anti-Black racism, classism, sexism, heterosexism, transphobia, and all other forms of intersectional violence, oppression, trauma in African Black people's lives as emancipatory. I want to end with Audre Lorde quote, "When I dare to be powerful, to use my strength in the service of my vision, then it becomes less and less important when I'm afraid." We talk about fear in our communities, thinking about the impact of anti-Black racism and heterosexism and other forms of violence on Black gay men's lives is a real issue of intersectional violence. And the bravery and risk it takes for Black gay men to do healing work is something that has to be not only respected, but understood. And as a practitioner, is a responsibility and accountability as a community member to support the health and the healing of Black gay men. Thank you.
Thank you, Roberta. Thank you. This has been a lot for us to start. So I ask that we just take a deep breath. Dr. Wilton, you talked a bit about anti-Blackness in your thing, but first, for us to ground the conversation moving forward, can you share with us in your own words what Blackness is?
Which now? Anti-Blackness?
No, what Blackness is first.
I mean, it's a broad question, but I think, simply put, I would just say Blackness has to do with Africa and the African diaspora and our cultural frameworks, our cultural systems and so forth. But it's not, when we think about, Blackness, we have to be thinking about more of a global, framework where we're not working within just one specific locale per se, right? But it's open to multiple communities and possibilities. So within the context of Africa, and if we look at the continent of Africa, I mean, it's vast, right? Are we talking about, West Africa? Are we talking about Southern Africa, East Africa, et cetera, but also within the context of the African diaspora, right? So, we're talking about the Caribbean and also within the Caribbean, where we're talking about English-speaking Caribbean, Spanish-speaking Caribbean, Dutch-speaking Caribbean, French, speaking Caribbean, like the Francophone Caribbean and so forth. We're talking about, Blackness within the context of the UK, you know, so it's open to multiple possibilities, and it crosses space and time and people's histories as well.
Okay, thank you. Because I asked that specifically because as we move forward in the conversation, I want people to have an understanding of what Blackness is. So as the conversation builds, people could see or make reference to Blackness. And I want to ask the entire panel before we move forward about, we've been hearing a lot about critical race theory, but it is my understanding that many people have different versions of what critical race theory is, or the importance that it would be for our work. So for the panel, can you share a bit about what is critical race theory? And then we can move forward into the Q&A. And the importance of understanding critical race theory for our work. Anyone can start. Hello?
Hi, it's Roberta. I think that Dr. Wilton talked about it in his presentation, and the importance of critical race theory, again, is the, looking at interdisciplinary ways and spaces of talking about race and racism, right? And you can do it from, your different locations, centering the experiences of race, racism. I think it's moving more than talking about the social construction of race, which is kind of something that has been talked about, but moving in terms of the practice of racism and also the practice of resistance or resistance against racism. So there's many, critical race theory comes from intersectionality. It comes from, Black feminist scholarship. It comes from lived experiences and knowledge of African Black communities locally and globally. There's many different understandings of it. I think there's a watered down that's happening, or kind of a whitening of critical race theory when it's happening in academia. And I think what good good folks do, I don't know any other word, good folks do is to talk back to that and remember and remind people the roots of critical race theory, that it comes from Black lived experiences and knowledge, and it comes from a space of resisting and dismantling systems. It's not just a theory that has no practice. The practice is to dismantle not only the impact of racism, but to challenge the conceptualizations of that we have in our white supremacist societies. Oh, you're on mute, Eric, you're on mute.
Sorry about that. Devin, do we have any questions in the chat?
We don't have questions. We have some comments. I can read some of the comments.
Please do.
From Adrian, basically, according to his program in Durham region, some of the Black queer kids in my program, there can be assumption of promiscuity, which carries a degree of judgment that can silence them when looking for information on sexual health. Feeling shamed in any way can shut down someone. And LaRon responded to this. And then one of the things I think, since we're talking about critical queer theories, critical race theories, how, with all the ASO folks here today, how can some practical applications, how do you apply that in your work settings or structures that we work in? Like what can people do to start off? Because I think since last year with George Floyd's murder, there's been a lot, everybody has been on the end to sort of do anti-Black racism. Well, anti-Black racism has been here for hundreds of years. Finally, there was like a wake-up call. But I think what can people actually do in the HIV sector? Because we did speak about, in terms of the structures need to change from LaRon's conversation, is not basically having new biomedical interventions. It's like if the structures stay the same, there's going to be no new outcomes in terms of health equity for same gender living Black men, right? So intersecting that with critical race theory, how can actually people adopt some practices that are realistic, that they can do in-house, that will actually make this on a day-to-day practice, because many organizations are getting training and stuff like that. But training is only effective if you apply it, right? So any feedback from three of your critical feedback would be useful.
It's an interesting question, Devin. This is just my initial thought. I think but there's two things. One is sort of a starting point is getting folks to understand that there is a system in operation. Like, I think that's the first thing, that this is not sort of just kind of the way things are, that it's a system. And that what role they have in maintaining it, once they can understand that it's happening. One of the things that I've done with, so in my research lab, there are mostly Black people in that lab, but my students are almost 99% white students. So every now and then I'll have them come to like my research lab, and then, just come to the meeting. And then afterwards, so what was that like? And nobody really says something up front, but then they go like, it was all Black people. It's like, oh yeah, you noticed that. And they go like, that was weird. Not weird, but that was odd to be in a space that's all Black people talking about these weird things that we were talking about, weird to them. And it also felt that the discomfort is that doesn't even feel like there might be a fair process. Like, really, like, you found all Black people to be in your lab. I was like, yeah, didn't that feel odd to be on this Zoom screen and see 32 circles with all Black faces? It seems like that just doesn't happen by accident. I say, that's how I feel when I come to this classroom and I see all these white faces. Like, I know that is not by accident, that is by design, right? And then they get like, oh, yeah, that is weird. Like, you would expect to see a whole range of faces on the screen if the system was fair. It's not. This system is designed to privilege you. You're the ones who got admitted. You're the ones who got in my class. This is how it is, and that is not accidental. That is not a natural order of thing. There is a system that is designed to make sure this happens every single time. Just as the way I had to design a system to make sure that my lab looks the way it looks. So then they get it, right? Because part of it, at least in this setting, is that I really don't, it's so normal, right? That it's not clear to them that this is a sort of a intentional system that's at play. So once they get it, sometimes there's a small window to kind of say, now what are you going to do about this? Because now you know what's going on. That is the harder part, because they also recognize, they grapple with their self-interest, right? They realize that to really do this means the potential of giving up some of the power and privilege that they enjoy, even if it's not something that they went out and grappled for. But they know that if this means that I'll have to compete on equal footing with Black people, can I do it? Could I still win if I just had to be a good human being and win my own merits? Like, I think they realize the implications of getting rid of the system that privileges them. So that's the challenge. The first part is the consciousness raising, and then the second is sort of the will to do it. And I actually think young people, there's something happening, I think, now with this challenging of these notions of gender, and the way young people are just kind of saying, we don't want to have to buy into that. And I think folks who are saying, why, even white skinned people who are saying, what identify people, why do we have to buy into this? And I think we should just burn all this shit down. Like, let's get away with these systems. Not all of them, but I think I see more of these coalitions between marginalized groups who realize the sort of commonality in both in their struggle, but in their interest in a sort of fair society or fair world that is likely to be the ones who do it. Not that it won't generate different types of resistance, but it seems like there may be some willingness to say, my struggle is linked to your struggle. Why don't we just all figure out a way to work together to do away with the way things are going? So I don't have sort of a concrete way to say how you do it,
Right.
but that's sort of how I try to do with some of it in the practices that I do, mostly teaching and research practice.
Leo or Roberta, are you going to respond to that question, or we can move on to the next question?
Yeah, I can respond. I wanted to join with Dr. Nelson and Dr. Timothy with their presentations, because I think that all three of us have been talking about moving the paradigm right? So real practically speaking, because I really appreciate the question because it's a very, very important question. But I think all three of us have been inviting us to think about systems and systems of care, right? And moving away from pathology-based models where we're focused on individual behavior, right? All three, presentations, invited us to think about that. So as opposed to putting the emphasis on individual behavior and what's wrong with the person based on these very problematic deficit models that are based in very Western, Eurocentric, patriarchal, heteronormative, et cetera, frameworks, moving to systems. So what's happening within the system? So let's put the report card not on the person, but let's put the report card on the system. What's happening on the systems level when a person is walking into the door, of an agency or a healthcare center, right? Are they feeling, invited to kind of be there? Like what's on the walls when they walk in? Who is there to greet them when they walk in, that sort of thing. So moving from the individual level analysis where, we're all trained in terms of, it doesn't matter what discipline, we're all trained in there. Psychology, public health, nursing, everyone, needs to be indicted, in terms of this. How do we move beyond these very regimented systems that we're trained in, where we, engage in thinking about systems, like I said, systems of care. That's where the emphasis needs to be. It's not on individual people per se, right? But it's on the systems. We need to be problematizing the systems and being challenging, our systems, because if we're looking at these very pervasive, very persistent, health-related inequalities, Dr. Timothy was talking about issues of violence, for example, and very, very rightfully so, that's grounded in anti-Blackness. But also, one of the things I heard that she was talking about is that, well, how can we move beyond these models to also really engage a very culturally congruent framework, that's grounded within the communities that we're working to serve, right? In terms of, resiliency and agency, and that sort of thing. So I would say those are some of the practical implications. Not too hard. It's not too hard, right? It's not too hard to think it through.
And can I say one more thing about that? Because I think, this relates a little bit to the critical race theory question, not directly, but, so I work a lot with nurses, and like there are very particular ways, maybe subtle, that violence gets enacted. Like I talked to somebody about who was upset about the way a person had come into this clinic, the way we're dressed, Black woman, right? And they said, this is a family clinic, they came dressed like this. And so they decided that, she'll just have to wait. And I said, do you know what that is? Like it seemed like, okay, well, a nurse had attitude, she's gonna make somebody wait. I say, but that's punishment. Like that is somebody wielding power and distributing punishment. They're taking control of this human being's time and liberty. They're deciding who gets to get seen when. We don't know what else was going on in this person's life. But I said, this is like, and would you have done that to a white woman, regardless of how she was dressed? Would you have done that to a white gay man, no matter how he presented in the clinic? I said, because you know that you could not do it and get away with it with a white person. And by consequence, you know that you can get away with doing it to a Black person. Like, and that is those things that happen. I'm using it as an example because it seems so trivial, but it's not. And it's these different ways that we use this that I don't think we call attention to and that we should. Like all this is reason why people don't come back, right, to your clinic, right? People make decisions about what type of treatment you're gonna give somebody, right? Based on what might be more punitive, what's gonna teach them a lesson. That's violence. That's you making a particular decision about how you're gonna show somebody through giving them a procedure that's gonna hurt more than one that you could have given it. Because you think, but if it hurts more, they'll think twice about doing it again. That's not therapeutic. That's traumatizing, that's violence. It happens all the time and it's normal. We hear it, we see it, and we might not even, you hear colleagues say it doesn't even cross your mind, right? Because it's, but if it was a white gay person, right, you would say, wait, hold on, that's, Is that what you want to do? And it doesn't think about it, because violence against Black people, I think, is so normalized, and against Black queer men, gay men, and how we think about, Dr. Timothy talked about the way in which we conceptualize how the presentation could and should be that are very Western. I mean, all that plays out in these clinics and these systems, and the system allows and then protects the people who do it. So, and I'm calling out nurses because I'm a nurse, because I agree with Dr. Wilton about indicting even all the ways that we participate in this, but all that is a part of it. It's not about what an individual is doing. We're producing this. The systems are producing these inequities. And so we have to find ways to change that.
I think Dr. Wilson and Dr. Nelson said it all. I think, the only thing I would add is, again, it's about, in these systems, not having empathy for Blackness, right? For Black people. So the violence of Black folk is a way of life, right? And even, the village, the so-called village on Church Street, the amount of anti-Black racism that has existed on that street for Black queer folks. And there's a long history there that continues to go on. I mean, I can't tell you the stories that if we in the queer community in general, if anti-Black racism is something that is rampant and violence, not talked about when we're talking about queer issues in general, then how can we then think that a system of white supremacist heteronormativity are going to care for Black lives? It's not going to happen. So as white folks who want to do conscious raising, and other racialized folks who want to do conscious raising, resist anti-Black racism work, cause no harm. Stop doing nonsense. Stop being anti-Black racist. I mean, I don't have the big words and fancy. Stop violating us. Think and feel and act differently. That's all I have to say, I think. Yeah.
Okay. All right. Thanks. Thanks, all three of you. Now, we've been talking around systems, and LaRon, you mentioned no matter what new comes up, whether it's the new type of PrEP for 12 times a year as opposed to 365 tablets. And you talked about that flat line that you saw with only white men, that it's going down. And we've seen we just had a presentation here, I think it was the OHDN, who showed similar numbers, where right now the HIV incidence is going down with white men. It's generally the rates are going down for gay men, but it's specific to white men. And we are seeing just the opposite with Black gay men. Now, what is something that we could do to turn this system around so that we get greater access to not just access, but the way that we engage, the way that to at least start to address the incidence rates around Black men, Black queer men?
Yeah, that is I mean, I think it's a hard question. I think I don't know if it's cynicism, is that the approach can't be narrowly focused on HIV or PrEP. I mean, I think that's part of what the problem is now, is that it's like, let's figure out how to do PrEP better with Black gay men or HIV. That won't work. It has not worked. I guess I'll say that. I think it's some of the things that Dr. Timothy and Dr. Wilton mentioned before is, I think we have to change. Like if I would do it, I would say, okay, we would take some of the people who run some of these agencies and we would replace them. We just take them out. We would, so that the logics of how you organize these things would be different. It would come from a logic, the way that Black people make sense in their life. Because right now they're not organized that way. I would, create a fund that would fund projects that came from out of Black communities. Not that had to be sort of filtered through white academic institutions or white ASOs who ultimately get to decide what the application will look like, because it has to make sense to that person from the agency who's submitting it. that means the interventions that we end up with are, even if they're Black, they're white washed or white, whatever you want to call it. So all that is the system sort of working. What I'm trying to describe are things that change the system, that change the structure, right? That redistribute the power. Because right now, everything still ends up through a white, mostly hetero lens or power funnel. And unless we change that, all the strategies that we come up with end up with the same outcome. So I think the issue is that there needs to be larger social change, larger structural change. You can see smaller incremental changes, but if you want to see that line go down on a population level, if you're trying to, so let me say this, if you're trying to see population level, change the population level trends, you need population level interventions. You can't do individual level interventions for a population level problem that you're trying to address. So I think we haven't done that. That's not a public health intervention. That's a political intervention and a social intervention. But I think that's what we need. And it might take a long time. I think increasing access, which is what some of these new products are designed to do, might see some changes in folks who are sort of have some material advantage at some level. But overall, I just don't think it's going to make a difference unless there's more momentum to change how these places are structured and to put Black people, Black queer people in a position to make decisions. Because I think it will bring everybody along. I think, when Dr. Timothy said Black feminism includes men, I was like, yes, of course.
Yes.
Like the logic is not one that excludes, that is designed to marginalize, right? So I think there's a lot of promise in doing that for everybody in society, not just for Black people. But that requires a different type of intervention. I'll just say that.
Okay, thanks, LaRon. We have a question from Flo that you want to share, Devin?
Adrian, you had your sign up earlier.
I did yet, but it's all right. I wanted to respond to your question, actually, Devin, about what can we do as ASOs in terms of programming change. For those of you who don't know, my agency, a white-led agency, runs a program for positive youth across the entire province. The majority of those youth who are transitioning from pediatric care to adult care are 85% Black youth. And we spend a lot of time doing workshops on how to navigate an extremely racist healthcare system. We bring in Black presenters and we bring in people to sort of really speak to agency and power. We don't have time to wait for society to change. These young people need this ability now. And so I love this conversation. But for us, what we found the most effective way is matching, and that's putting peers with peers. Because often what we found is that young people of color are better advocating for their friend than they are for themselves. And so we encourage them to book appointments with their clinics and bring someone in with them into that meeting, because often that person can then provide them with the agency and the ability to stand up for themselves and demand the same level of care they would get as a white person going into that space. We also sadly have to talk about that whole piece around keeping your cool, and that the power there is completely unbalanced, and you need to go in there and keep your cool and be firm, but be polite and respectful. And I know that the fact we have to have that conversation sucks, but I need tools that they can use every day to get what they need from their healthcare providers. And most of these kids, they live in suburban, semi-rural communities, and they're not all in downtown Toronto, right? And don't have access to the same level or number of Black-led services possible. So I get everything you're saying is awesome and it's wonderful, but really, I think the focus comes on giving them the tools to navigate today. So I'm sorry if I'm speaking out of turn and my total whiteness. I'm Irish, you can't get more whiter than me, but I feel passionate about these guys, and you've met these kids, LaRon, you know what I'm talking about.
Yeah. But thank you, Adrian. I want to go to Roberta, you were talking about it takes a village to heal, yeah? Which I totally agree. But for the community to move forward, healing is a priority. But in the aftermath of the murders of Black men that we've seen this is the first time in our lives we have actually seen things like this on television, right? Or across social media, which had a greater impact. Plus, it's in the backdrop of two pandemics going on at the same time. The overdose crisis, which we are well represented there, but for some reason, we don't see that in the media, right? But to drown out some of the noise within the community around the call out and cancel cultures and the different perspectives around politics and viewpoints, how would you, what type of approach or process that we're going to use to start to do our own in-house healing in order for us to start healing as a community?
Thanks, Eric. I mean, that's a beautiful question. You know, it's a question I think about on a daily basis and try to participate in. I think there's different conversations that we need to have. So one, there's some conversations that we need to have that are only within the Black community. And these conversations are conversations that are dealing with the, you know, transgenerational trauma, redirecting or readdressing our notion of Pan-Africanism. You know, there's a whole history and history of Black queer folks being a part of Pan-African movements, civil rights movements, Black movements, even, you know, even the recent Black power movement of, you know, this generation. We know that exists. However, when we come to our healing and the conversations, we have to have spaces that don't have the white gaze. So there's conversations that we need to have in the Black community, in the Black queer community, that are very different. And those are things that we need to talk about, the impact of internalized white supremacy, you know, Black violence against Black folks by Black folks. What does that mean? That comes from white supremacy, but understanding it, unpacking misogynoir, unpacking heteronormativity, homophobia in our communities. Again, when in the conversation, the notion of Black people being more homophobic than anybody else, our world is homophobic, our world is transphobic, but part of anti-Black racism is to say that Black people are more homophobic than other folks and putting that response. So we need to really look at how we have these conversations in safer spaces. There's a whole conversation about African and the diaspora. My family, I'm West African. I come from an enslaved history. You know, my family is French speaking, English speaking, Spanish speaking from colonization, from incarceration that we've experienced. But we need to figure out how to communicate as African folks amongst each other, the differences. And also, even I would say a part of the healing is even talking about reparations. You know, like healing, and like again, my whole fight for addressing health violence is reparations and asking for monies and funding back to actually deal with some of these conversations. Collective healing does not mean that there's one voice. It means that there's different ways of using different African traditional knowledges to actually heal our communities. So, you know, I do it in a small way through my practice. Anti-oppression psychotherapy was developed from African Black feminism. It's an intersectional perspective that challenges Eurocentric healing. The notion of even racial trauma to me is problematic. It's not racial trauma, it's racist trauma. When you're experiencing violence from anti-Black racism, it's racism. You know, when you get followed in the store, they don't say to you, hey, Eric, are you from Trinidad? LaRon, are you from the States? Leo, are you from the States? They follow you as a Black man. They don't actually necessarily even your sexual orientation, but you're being followed in a particular way. And I also want to say that happens for Black women also, right? And queer folks, trans folks. So healing collectively means finding spaces and places to have these conversations and actualizing different. For me, it's something that I grew up in. I practice African traditional spiritualities. The generations, my family, my grandmothers were folks who were, you know, our spiritualities were banned. And we practice that. And a part of my own healing practice for myself is going back to the ancestors. There's many different, I have, you know, different practitioners in my family, Christians, Muslims, everybody, African spirituality. There's conversations, there's conflict, there's everything. But if we're talking about healing Black community from anti-Black racism, heterosexism, sexism, all these pieces, we have to figure out a way to collectively, as heterogeneous peoples, heal. And that has to do with conversations, has to do with forgiveness. It has to do with stepping up and stepping under. You know, boycotting is something that we've been doing for 400 years. I grew up boycotting products. Like, I know it's really big now, but it's something we've always done. But it's more than boycotting a product and introducing, you know, healing and love to our Black community members. How do you address each other? You know, if you're in a Black queer community and you go to Blockorama and Black folks are there celebrating, but also when they're not in the spaces, there's some Black folks, you're like, hey, what's up? They're not saying hello to you. You know, they're with a white person, they're not saying hello to you. And that feeling, I've talked to different people who've experienced, you know, different pieces, and they'll say, well, the Black community doesn't love me, or I can't talk to my Black community. They don't really think I'm a different type of Black queer. We need to challenge these types of boxes and open up the conversations to really continue, you know, these hard conversations about healing and love for Blackness, which is a larger conversation. And, you know, Eric, we've talked about different ways and spaces of how to do that. But number one is to actually have those spaces, make those spaces available, and make them Black centered. It has to be Black centered. So that's some of my answers. Like, I could go on, but I'm going to
stop. Thank you so much.
Let me add a really quick, Eric, tiny 10 seconds is, I think what Dr. Timothy just described are also tools. I mean, I think if we can think about what Adrian offered in his comments about so very specific tools about navigating systems as oppressive as they might be, I think we need other tools that are affirming and healing that aren't just about how do you navigate oppressive systems. So we need all of it, but I think those are just as important because people live life outside these very particular systems too. Yeah.
I just want to add one thing. Sorry, I know I said I was going to stop, but you know, I'm a Black woman, so I'm going to say one thing. Also, that notion of I'm a transgenerationalist, which means that I believe our elders need to be put up. I grew up with elders in the community have to be put. Our youth and our elders, middle age, the maternal health issues that we're having in our community, all of these things need to be talked about. So in our healing, we have to also go back to our elders and the elders who are conscious and deal with the elders who did not get that consciousness, right? And are dealing with some of the internalized stuff, and also support our elders in our community, because I think we always think about youth. We were youth once, now we're getting older. There's going to be youth there, but we really need to have that transgenerational lifespan approach, quote unquote. Black folks have always done that. We've always had those, you know, our grandparents, our ancestors, our little children running around the party, everybody boogieing. You know what I'm saying? That's how we do. And we have to do the same for our healing. So I just want to bring that up, the importance of our elders, and that the memory and that the experiences, knowledges also need to be incorporated in our healing circles. Yeah.
Okay. All right. Thanks, Dr. Roberta. We have 1 minute, and I want to make use of this minute. And this is for all the panelists. I recently came across this quote from Rabindranath, a Bengali scholar. This quote was done in 1913, but it's still relevant to me today. The one who plants trees knowing that he'll never sit in their shade has at least started to understand life. I'm going to repeat. The one who plants trees knowing that he'll never sit in their shade has at least started to understand life. And now, in the context of our commitment for continued activism around anti-Black racism and stuff, what are some of the things that you think that we could do or put in place that would benefit our next generation? Because Leo, Dr. Leo, we've been around for a long time. You know, we on our way out. Dr. Roberta, we all have a certain age. LaRon, what are some of the things that we could put in place now that could be effective or benefit the younger ones that are coming? And this is going right back to your last comment, Dr. Roberta. Yeah.
Mr. Peters, we still got some time. You said we on our way out. We still got some time.
You know, I mean,
we ain't going nowhere quite yet.
Yeah. Yeah, so really quickly, anybody can start.
That's funny. You know, when you said the question, it actually brought tears to my eyes, I think. I have to say that from the legacy of our peoples. You know, our ancestors have done so much, and we are a part of those flows and you know, I don't know the language of those things. I think that, even here having like, if we could have, you know, some type of gatherings like around locally, globally, on just like Black unification, what does that look like? Coming from, you know, a African feminist, you know, queer positive perspective would be a part of those conversations. I hope that every piece of work that we do here is a part of the legacy of, you know, decolonizing and resisting anti-Black racism and homophobia. But I think there's other spaces, like we need to create bigger opportunities to have conversations, particularly about healing the impact of African enslavement and decolonization, which comes under a larger place. We talk about it here and there, but we don't have spaces of healing for our communities. So doing that, agencies offering, you know, you want to do something, give us funding. Money, it's always about money, revolutionary money. To be able to do that, I think would be one way of doing that. That quote speaks to my heart. I every day I try to add a leaf or a branch to a tree that's going to lead to the next generations.
Yeah. Thank you. Thank you. Dr. Leo or LaRon, who has jump in really quickly.
Maybe I'll say, you know, maybe a more comprehensive understanding of the history they're tied to. You know, I was in China January last year in Hunan province, and I was having a comment. I was at the museum, and somebody made a comment that was awkward to me, which was about Africans, African Americans, African Canadians, about sort of what they call progress. And I was kind of like, it's probably what they saw on the news, but they were saying, he said, well, you've only been there for a couple hundred years. And it felt odd. So I asked, but he said, well, we've been here for 5,000 years. Like, we know the Hunan people, like, we know what that is. And they were saying, yeah, you're in Canada, you're in United States, but in their context, that's like this. Like, you just came from Africa. And it was dawning on me that my sense of my history at that point really didn't tie intimately in the way that they was looking at the sort of larger global picture. Like, in their history books, they talk about this, when that migration, forced migration from Africa to Turtle Island, North America, what it is now. And I didn't see it that way, because I don't have a concept of a 5,000-year history of people that I'm connected to in the way that they were doing and explaining to me. And I thought where I might be, or my family might be, if I understood that for the last 44 years. And I didn't. I understood it last year. So I think that would be something important to leave if we can find ways to develop and convey that. And some of that is happening, but I think that will be important.
Dr. Leo, I want us to wrap this up as quickly, so not to force your hand.
In the interest of time, Dr. Timothy and Dr. Nelson said it perfectly.
Okay, great. Thank you. So for those who stayed back, but first I want to thank the panelists. I think the time went so quickly that the amount of talk that we planned to, that it has not yet happened, but it will continue on, another place, another time, another space. So I thank you all individually, Dr. Wilton, Dr. Roberta Timothy, and Dr. LaRon Nelson. Thank you all, and I thank those who stayed back for the time. We appreciate it. Thank you all.